Our next speaker for the day is Dr. Krishna Sheshadri. He's already been introduced earlier, so I'm going to ask him straight to get onto the talk, and he's going to speak to us about choosing the right patients for SGLT2 inhibitors. So the stage is yours, Krishna.
Thank you, Sanjay, and thanks for having me in this program. It's not as good as being in Pune, but I'll take it as it comes. And thanks for the hospitality that you extend each year. If you notice in most conferences now, and you know, even in ours today, SGLTs have taken most conferences by storm. But what it sort of leaves behind for many of us who are in primary care is, okay, all this information is fine, but who do I give these drugs to? Who do I not? And what do I take? So what I've done is I've distilled down a workshop that I do for practitioners, and you know, retained its essence and made it exceptionally simple to think about it. And what more can you have to make things simple than have patience? So these are my conflicts of interest. I have speaking honoraria for many
You haven't shared the presentation.
It is.
No, you've got a word sheet on.
Oh, I'm so sorry.
There's the Octet Endo meeting word sheet.
What worksheet is there?
Octet Endo meeting at Chennai.
Let me see. Okay, so
stop sharing and then again share.
I'll share it again.
Yeah.
Now?
It's just started.
Okay, so great. So these are my conflicts of interest. I have speaking honoraria for most SGLT2 talks that I give. So let's look at this patient, 54-year-old woman, type 2 diabetes, 7 years on multiple medications. Height is 161, weight is 82 kilograms. eGFR is 92, and urine albumin creatinine ratio is 22, A1C is 8. So let's quickly go through the questions that we will. What is the target A1C? What are the drugs that will bring you close to the target? And are there any other additional benefits of the drug in this situation? And most of you who know this well know that the A1C for this patient who's had diabetes for a while, a good way is to look at 7%. Is an SGLT2 inhibitor useful in this situation? When compared to a DPP4 inhibitors, what are these better choices? We know that SGLT2 inhibitors have been around for around 5 years. There's a large body of evidence. You've been hearing it throughout this meeting, in many other meetings that you go to. We know it works by preventing glucose reabsorption, increasing the filtration of glucose. One of the drugs that we use is dapagliflozin. Most of the stuff that we talk about in terms of DPP4 inhibitors can be classified as a class A effect. When compared to a DPP4 inhibitor, which is something that all of us keep wondering what to use, we know that there are 4 important benefits for SGLT2 inhibitors. One is they cause weight loss. One is the second, they have benefit in ASCVD. They have benefit in preventing established ASCVD, I'm sorry. They have benefit in preventing heart failure. And now we have some data about heff also. And clearly they have benefit in terms of PKD. The DPP4 inhibitors are wonderful diabetic lowering agents, but these 4 effects are better with a SGLT2 inhibitor. We have data on the use of SGLT2 inhibitors as monotherapy with metformin and as combinations. In each of these, the A1C reductions are consistent between 0.6 and 1. And in most of these, there is also additional benefit in terms of around 1.5 to 2 kgs, especially with dapagliflozin in this particular study. So clearly, we know that it can get you closer to the A1C that you require, right? And it will also cause some weight gain. But should you do anything else for this patient? What additional history should you obtain? Any other testing that is warranted, and how do you educate this patient? Most importantly, make sure that you don't have any other problems, especially with the urinary tract infection. If somebody has urinary tract infections and recurrent urinary tract infections, recurrent vulvovaginal candidiasis, and these are not patients that you should be using this drug for. The most important test that I would get in any patient is an EGFR. Remember that as the EGFR comes down, the glucose lowering ability of the SGLT2 inhibitor comes down. However, its benefit increases simply because as an off-target effect, it works in DKD, and we can talk about it. The side effects that I educate the patient is one is non-hyperglycemic ketosis that patients can develop in insulin deficient situations. And of course, urinary tract infections and genital mycotic infections. Also tell them that if they test their urine for glucose, it will be positive and not to get worried about it, and would not advise it to women who are planning to or are pregnant. How do you prevent genital infections? Genital hygiene, adequate hydration, and of course, talking to a doctor when this happens. Indeed, in this particular patient, this happens. What would you do? Would you stop the drug? Can you treat through the infection? What if there's a recurrence? I think most of us now agree that you can actually treat through the infection. For simply vulvovaginal candidiasis, I use 3 to 5 days of a vaginal pessary. If there is recurrent infection, I would stop the drug and then maybe even use oral fluconazole. In many patients, after some time, I actually try re-attempting introduction of the drug, especially if it's important, and I'm using it in heart failure, renal disease, or in patients with, established coronary artery disease. So in this patient was treated through the infection, the itching settled, and you can notice that her BMI has come down, her sugars are fairly close to normal. And remember, there was glucosuria, and all you have to tell this patient is that this is how the drug works. Do not use, and you really don't have to get urine glucoses regularly. Tell your lab to stop measuring it, and this way you can get this headache off your head. She's fine, she's asymptomatic, but the weight loss is not continuing. And also there's a mild drop in EGFR. What should you do? One, remember that the weight loss does not continue after some time and plateaus simply because the body actually slows down its metabolism. There is also an important part to it, and that there is an increase in intake. So one of the things that you should talk to patients about is that they should continue to be on a diet. And if they don't continue to be on a diet and they loosen up, they will gain weight after some time. This is one bit. So there is an adaptive increase in energy intake. This was work that was done by Ferranini et al. The second thing to tell patients, of course, is to also use other drugs in combination. And we won't do it today, but an SGLT2 inhibitor plus a GLP-1 RA is an amazingly potent combination. Also important to understand and tell patients that the initial dip in the EGR is very important because it tells you that over a period of time, how this drug is going to work and help your kidney. One of the things that simple way to look at this is the serum creatinine up by more than 30%. If it is, check for volume status, depletion, and acidosis, and consider stopping the drug. On the other hand, if the increase is less than 30%, continue the treatment with an SGLT2 inhibitor. This is a treatment effect and a very desirable effect at that. So we sort of understood what to do with patients who are to add on to drugs. What about a patient who has established cardiovascular disease? Here is someone who's 55 years old, type 2 diabetes for 10 years on multiple medications. EGFR is 60, albumin creatinine ratio is 70. You notice that, I'm making a specific mention of EGFR. The reason is for us to understand that this is a calculation that we must do for all particular patients. You know that this patient will do well with an A1C of 7.5, but what are the priorities for this patient? Here an SGLT2 has both indirect effects in improving glycemic control, reduce insulin levels, a whole bunch, but there are some direct effects on this patient in the kidney as well. So in patients with reduced EGFR and albuminuria, are there benefits of adding the SGLT2 inhibitor? Is there evidence to support it? Absolutely. And this is where the DAPA-CKD data comes in. you will notice that the hazard ratio in this particular study was 0.61 with a 95% confidence interval. And you can see again the separation of curves by around 8 weeks. It's a very, very, very substantial thing. And the primary outcome in this particular study, which was a combination of endpoint, which was a sustained decline of EGFR of 50%, end-stage kidney disease, and death of renal and CV diseases, you will realize that irrespective of the patient being diabetic or non-diabetic, in the presence of proteinuria, there was clearly benefit for the patient. And that is why today, if somebody has CKD and albuminuria, the drug of choice is an SGLT2 inhibitor with evidence for reducing CKD progression. Right. The question, of course, that many of us ask is if DPP4 inhibitors combined with SGLT2 inhibitors, are there added benefit? Because this is one of the most common combinations that we use. Theoretically, there seems to be a lot of benefit, especially because at least at the albuminuria, there is some benefit with the DPP4. But overall, no one has demonstrated in a meta-analysis that the combination has added benefits. But at least we know that there is no harm. The SGLT2 inhibitors increase glucagon, the DPP4s decrease it. But what is important to understand is they work fairly well together, but not necessarily additive. They are quite complementary. That brings us to our next patient who was admitted with a STEMI and a PCI. 3 weeks later, he comes to you, no history of diabetes, glucose is around 160 to 180. He's on cardiac medications and statin. What should you do for this patient? This patient, of course, the A1C is less than 7.5, is an OHA indicated. What should you do? In this particular patient, irrespective of whether this patient requires another diabetes medicine or not, I would add an GLP-1RA with proven CVD benefit or an SGLT2 inhibitor with proven CVD benefit. His EGFR is around 90, so it's a flip which of these drugs that you want to use. But clearly, an SGLT2 inhibitor is an oral drug and work. That brings up the question: should metformin always be the starting drug? And can a patient be started on SGLT2 inhibitor monotherapy? And can we use dapagliflozin in this context? So the ESC's algorithm now tells you that in drug-naive patients who are ACVD high or very high, start an SGLT2 inhibitor or a GLP-1RA monotherapy. And this, while this is path-breaking, it's not unusual. And also there are some studies that tell you that metformin actually reduces the effectiveness in an SGLT2 inhibitor in this situation. Whether that is something to be believed or not, I think there is a lot of data to start thinking about SGLT2 inhibitor monotherapy and not necessarily think of metformin as a Ganesha of type 2 diabetes. This is a sub-analysis of the TIMI trial that told you that in patients with previous MI, there is a relative risk reduction by around 60% in the MACE and a greater benefit for MACE within 2 years after the last event. And again, many of us believe that this is a class effect and can be used. This patient is a 65-year-old under your care for diabetes, has diabetes and hypertension for 15 years, complaining of shortness of breath with some activity, third heart sound and mild pedal edema, has an ejection fraction that's around 40%. So he's on saxagliptin, metformin, gliclazide, EGFR is 70, UACR is 35. So even without the heart failure, he already has some indications to start an SGLT2 inhibitor. But what are the things that you would do? Clearly, many of us will tell you, stop the saxagliptin. But what about the other drugs? So the SAVOR-TIMI clearly showed that in patients with on saxagliptin, there was a slight increase in hospitalization for heart failure. And the FDA's advisory, not a black box warning, but an advisory about heart failure for all of these things, right? So we know that there are drugs today. The drugs for heart failure include a beta blocker, ARNI, and an MRA. Other drugs, which I won't go into. I'm not an expert on this, but these are the 4 cornerstones. This is the DAPA-CKD trial. People have talked to it again and again. I'm just going to tell you that the inclusion was class 2 to class 4, left ventricular ejection fraction of 40%, NT-proBNP of greater than 600. There was a reduction in hospitalization irrespective of diabetes, there was a reduction in all-cause death, consistent across all the subgroups, all the renal function. So he's a diabetic for 50. So let's change this slightly. So clearly we know that in patients with compromised heart failure, HFrEF, the reduced ejection fraction, there is benefit when using an SGLT2 inhibitor. What about someone whose 2D echo is 56% and LVH? This is someone who has what we call heff, right? There is no reduction in ejection fraction. And when I first gave this talk, I had written underneath this, there is no evidence. But now we know with the Emperor Preserve study that there is benefit, that the hazard ratio, this was empagliflozin, a hazard ratio 0.73, confidence interval of 0.61 to 0.8. Just to let you know that the benefit was more with the ejection fraction between 40 and 50 than between 50 and 60. And importantly, other than the primary composite outcome and the hospitalization for heart failure, none of the others were very significant. In fact, there was a divergence in between the HFrEF in the Emperor Reduce and the Emperor Preserve in terms of the renal outcomes that have led a lot of people to ask many questions. But we are not here for the evidence, we are here for what is practical. So remember that the HFpEF ratio data is very encouraging. Even without that, I think this patient with a lower EGFR deserved an SGLT2 inhibitor. That the DELIVER trial is coming that evaluate dapagliflozin in HFpEF. But let's move on with our patients. 57-year-old woman with type 2 diabetes for 10 years on insulin. Can you use insulin, SGLT2 inhibitor, reduced dose in insulin? The answer is yes. What does it do? Here's a meta-analysis of 7 studies, right? There is a reduction in A1C by 0.56%. And what is important is that there was a weight loss in these patients because weight gain is very common with insulin. And there was a reduction in a dose of around 9 international units, right? This is another one that looked at the glycemic variability. There's a reduction in insulin, but not necessarily a reduction in glycemic variability in this particular study. The other important thing to remember, and I just want to emphasize to you, that in patients who are thin, on whom you're considering adding an SGLT2 inhibitor to insulin, be very careful, especially when they have to stop the insulin, the risk of euglycemic ketoacidosis. Lastly, this question is added simply because there's so much pharma interest in dapagliflozin. Here's a patient who's on a dapagliflozin MF. Current visit, he asks, he has heard about lower dapagliflozin and asks if he can switch. Remember that after a certain amount of time, there's a difference between biosimilars and generics. That the law allows you to make generics. The important part is the PK, is the bioavailability and the bioequivalence. And if the bioequivalence is fulfilled, and it can be seen on this particular study, and you really don't need other studies for the law for the regulators to tell you that that the A1C is equivalent, the fasting glucose is equivalent, the creatinine is equivalent, the mycotic infections are equivalent. But I think many companies have established that. And as long as you've looked at the data and you can see that they are interchangeable in terms of bioequivalence and that their potency is the same as the innovator, I think all the innovators have a good amount of time for ROI and continued care. We will need competition to make sure that these are affordable, that there cannot be a group of patients in the country where where they cannot reach drugs. This has to be either by regulation or by distribution or by encouraging competition. And either of these 3 mechanisms will allow patients to get drugs. So let me summarize. What I've done is I've sort of cut through many of the data and lots and lots of data actually make us the same. I hope I've tried to give you situations in which SGLT2 inhibitors are indispensable, are useful, can be used in combinations. And hopefully I've also answered some of the common questions that we have. Can we treat through an infection? Can I combine it with the DPP4 inhibitor? Should I give it in somebody with a lower EGFR? What happens when I give it to a lower EGFR? Can I give it in heart failure? Can I give it after an MI? Can I give it after HFpEF? So I hope this was simple enough for most of you, and I'm happy to take any question. I also think I finished well within time. Thank you, Sanjay and Neeta, for constantly having me in this program. It's an important part of my calendar, and I consider it a pleasure to be part of it. Thank you again for letting me moderate Dr. Tuttle and Sundar's talk yesterday. That was also a wonderful way for us to understand many things. Thank you both.
Thank you very much, Krishna. It's always a great pleasure to have you on our show. I think yesterday's, the entire interaction and today's lecture have been absolutely fantastic, very informative, lots of take-home messages. I don't see any questions that I have for you because your lecture has been so self-explanatory. So I'm going to really let you off the hook for today. Thank you so much.
Thanks, Sanjay.
for being part
Bye-bye.
of this meeting. Thanks.